Good evening, and on every Thursday, as I like to say, happy Friday Eve. I'm Ebony JJ Curry, senior reporter for Michigan Chronicle, and I am excited to be here today because this conversation always allows genuine and very open conversation around 340B program, and that is all things community and how it impacts our community. Welcome to What New Yorkers Do Best and how we are exposing 340B loopholes. As some of you may know, the 340B program was created with a noble goal, which is to simply help hospitals and clinics serving underserved communities provide life saving medications at a reduced cost. And, for Black and other minority communities disproportionately impacted by chronic illnesses such as diabetes or heart disease and cancer, programs like 340B are extremely essential to improving health outcomes and making care more accessible. However, without proper oversight, this well intended program has strayed from its mission, leaving vulnerable patients behind. And today we have amazing panelists to truly talk about this program. I'm going to start with Miss Sally. If you don't mind going ahead and introducing yourself, and then we're going to go with Amanda and Garina, and just give a minute talking about your relationship with 340B program and what it is you do.
Sure. I run a nonprofit organization in Washington, D.C. It's a national organization that does consumer and patient advocacy and worker advocacy as well. And we spend a lot of time on healthcare and concerned about patients getting affordable, accessible, safe medications. And we want to make sure that programs that are intended to help patients to pay for the cost of their drugs and their treatment is going to the right place. So the way we got into 340B is we kept hearing about this program that provides a huge discount to hospitals and pharmacies, many of the big chain pharmacies, with the intention that when they get discounts on these drugs, and there's billions of dollars of discounts going to the hospitals and these pharmacies, they're going to pass along those discounts and relieve some of the burden, especially on lower income patients, of the cost of medications. So we learn about this 340B program, which was passed in the early 1990s, and it becomes clear over the years that because of lack of transparency and not enough specificity in the law, that these drug discounts are not going to patients. They're in fact going into the pockets of hospitals, and you might have seen hospitals expanding their real estate, and you go to some cities and every block there's a different branch of the hospital. And so that's where the money is going, and it's going to pharmacies that are already doing very, very well, and they're not passing those drug discounts along to the patients. And I'll just close this part of my opening statement. Hospitals participating in the 340B program only invest $1 in charity care for every $10 in additional income they make. So it really does raise questions about whether this 340B program, very lucrative for hospitals, very lucrative for pharmacies, is going where it's supposed to be going. And that's why we're calling for change.
Thank you for that, Sally. Amanda, I would love to hear from you.
No, that was wonderful. Thank you, Sally, for framing the conversation. My name is Amanda Septimo. I'm an assembly member. I represent the South Bronx in New York. And I've really come to this 340B issue because it can feel a little sort of niche. If you're not really in the weeds and familiar with this kind of work, it sounds kind of jargony. But I sort of heard of the idea of expansion of this program. Anytime we're talking about expanding something from a policy perspective, you want to kind of do your homework. And as I've sort of gotten into learning more about it, I've really been alarmed by the nature of how the program is functioning and the disconnect between what's intended to happen and seemingly what is happening. And that's been even more amplified by the fact that I meet people who have stories that are horrifying and that shouldn't happen if this program is functioning the way that it was meant to. And so with that, we've introduced a transparency bill here in New York that would really shed some light on the process, just to understand, how is this program working effectively here right now? What's the role of contract pharmacies? What's the role of the hospitals? How much money are they taking in? How much of that is being reinvested into community as intended? And if we have gaps, how are we going to fix them? And so I'm really proud to sponsor that legislation, and I'm hopeful that we can get it over the line, so that if we're going to talk about expanding what should be a great program, that we're doing it from a very informed and responsible place.
I love it. Thank you so much, Amanda.
Sure.
Yarina, please feel free to go ahead and give us your spiel.
Yeah, thank you, Sally and Amanda. The same here. I am looking, I have was brought in through Tiger Lily. Tiger Lily is a nonprofit organization that help women diagnosed with breast cancer at the age of 15 through 50 years old. As a breast cancer survivor, I am on the side of being a patient and now learning more about the 340B program as an advocate. So I would like to continue to learn more information. That way I can take that information back to the community, because even as a patient, I was not aware of this program. And I don't know if it's because I'm not considered low income, or my insurance was just that amazing that, it was just being billed, and, my copays was being met, and, my deductibles were being met. So I was not a part of that community that this program is supposed to help, which is the underinsured and the uninsured. So, and the low income within the Black and Brown community. So I am here today to continue to learn more information, to continue to dig more into this program, that I can take it back to my community and to let them know that this is something that is out there for you and that can help you, because no one should have to decide whether or not they're going to be able to get their medicine, or they're going to live, or they're going to die. So I'm just here to continue to learn more about the program and continue to advocate for those that do not have a voice and that do not know about what's going on with this program.
Absolutely. And first and foremost, thank you, ladies, for being here today. Super excited to dive in deep about this very important topic. And Garina, to your point, there are a lot of people who's watching right now who wants to learn more about 340B, the 340B program, and who probably has had similar situations such as yours. Super excited to have all of these women from different walks to really give their idea and their thoughts on this program. To those of you who are watching, I want to kind of break it down a little bit about exactly what we're talking about today, if you may not know. Transparency and accountability are necessary to protect vulnerable communities who rely on these savings for essential healthcare. As simple as that. While pharmaceutical manufacturers are required to offer certain 340B prices, there is absolutely no clear requirement ensuring those savings directly reach those patients, hence Garina's stance. And instead, reports indicate that some hospitals and pharmacy chains have leveraged the program to boost their bottom lines. And as a matter of fact, a New York Times investigation revealed some troubling trends, including hospital chains acquiring community hospitals in underserved areas. Now, it's not to expand access to care, but it is to qualify for lucrative 340B discounts, again, that benefits them. Only 15% of 340B contract pharmacies in New York are located in low-income areas. And in layman terms, that means that the very patients who should be benefiting most from these drug discounts are often left out, which brings me to this question specifically aimed towards New Yorkers. And Amanda, I would love to start with you. What do everyday New Yorkers need to understand about how the 340B program affects their local healthcare access? And why has that understanding been historically limited?
That's a good question. I think the I'll start with the second part first. Like I mentioned, I'm a legislator. This is my 5th year serving on the state level. I've worked in government for many years before that, and I'm just sort of learning about the 340B program. And so I think our healthcare system is one that's set up in a way where information is generally difficult to access. And you layer this with the fact that 340B drugs are traditionally cancer drugs, right? The really expensive, hard to access drugs. When you are going through cancer, or you're a family member supporting someone going through cancer, that is in itself a harrowing, life-changing, destabilizing experience. And so to expect people to also be able to do the research, to get into the weeds, to figure out the jargon, it's just not realistic, right? And I think that that's an indictment on our healthcare system overall, and the fact that our healthcare industry functions very much as a business in this country. And that's, I think, for another panel, another day. But that's certainly one element of it. But I think the other side of it is that we're not getting this information out. And I think that speaks to the idea that maybe it's because some people would prefer that it's kept more of a secret, that this continues to live in the dark, and that people are able to profit off of it in ways that are not serving community. And so for the average person, in terms of what should they know, how does it access, how could it impact their access to healthcare, I think it's to say, we recognize that there is a problem with how healthcare is administered in this country. We know that people get put into impossible situations where they're needing to access a life-saving drug and don't have the money for it and are put in this really difficult situation. That's what the 340B program is supposed to help with, those very people. And the point of all of this is to make sure that we're at least having an answer to that problem in our system. And so in terms of people understanding how it could impact them, it's that think about, unfortunately, we probably all can think of an example of a GoFundMe page that we've seen for someone who's sick, who's needing to access a healthcare. This program is supposed to make it so that at least people dealing with cancer accessing medicine don't have to make a GoFundMe page. That's how I boil it down into sort of the plainest English.
I love that. When it comes to layman terms, I think that meets people where they are, because this is, directly towards everyday people. And Sally, I want to hear, your thoughts on that. I want it to be as cut and dry as Amanda, and very much so layman terms. What do everyday New Yorkers need to understand about how the 340B program affects their local healthcare access?
Well, we could do, so I'm a policy wonk. So my go-to is always, how can we change the law to make it better for, and I'm guessing Assembly Member Septimo joins me in wanting to use the law and do reforms where we need to do them. We actually need a federal law to be reformed, because the program is a federal program. But states are doing interesting things, sometimes in the wrong direction, because you've got hospitals coming in and pharmacies coming with lobbyists saying, we love this program and enable us to do charity care for all these people in the community. And I think my response to that is, okay, open your books, show me this charity care you're providing. If you're providing 20, 30, 40% charity care, and you're providing 50, 60, 70% discounts on drugs, the way the program should work, or whatever it is, that whatever number but you're providing a very hefty percentage of discount on drugs, okay, then the program's working like it's supposed to. But when you're talking about 1% of charity care, and this is a $66 billion program that these entities, the hospital, the covered entities, the hospitals, and the pharmacies, the contract pharmacies are pocketing, then I always analogize it. So let's say, your father, your mother gave your brother $1,000 to take you to dinner and pay your bills and to pay your school costs. And instead, your brother's using that money to go out to eat and have a fine old time and play poker and all this kind of thing. And yet that money was supposed to go to you, but it's not going to you, as he's having a good time doing, and maybe he's doing some good stuff. But wouldn't you be mad wouldn't you be angry if the money that was supposed to be going to you is instead going to somebody who is not using it for the purpose in which it was intended? So we need federal reforms on the bill, and we have tried. It's getting federal law changes is a slow process, but I think panels like this are shedding a light on what the problem is. And of course, I want to, Ebony, I want to talk about our survey of New Yorkers, because we just released our 10,000 person survey today. Like you said, Assembly Member Septimo, most people don't know this exists. Certainly, Garina didn't know this program exists. She didn't know that she should be getting help with her drugs and other kinds of discounts. But the medical debt problem is a huge problem. And these very hospitals that are pocketing these gigantic overages of money from the 340B program are turning around and suing patients for medical debt. And medical debt's a huge issue in America.
Yeah.
So I want to talk about that. I want to turn things over to my co-panelists, but we'll come back to that hopefully, Ebony, and I can tell you what the survey shows and how medical debt is weighing down so many Americans.
Absolutely, Sally. We're definitely going to get into that survey, because I think that's a huge piece to this conversation as well, especially being that it just broke out today. I do want to circle back to Miss Amanda. As we talk about policy, I want to stay in that lane. What specific policy or oversight gaps allows that disconnect between intent and outcome?
Well, so really, the gap is the entire space. I wish to describe it as a gap is really sort of just a term, but we actually have no insight. And that's the problem. And so the legislation that we've crafted in New York would make it so that it's very simple. Folks would simply just hospitals would just have to report how many drugs are being prescribed, how many prescriptions are being filled at contract pharmacies, where are those contract pharmacies, how much money is coming in terms of savings, and then how is it being turned over? How much is being spent on charity care? So to Sally's point, we have a clear lining out of saying how much is coming in, how much is going out. Simple. Right now, we don't have that accounting. And I've got to tell you, to me, it's information that should be readily available, right? Because we all know in 2025, it is very easy to pull data that you're already collecting and put it into a chart and get it together. So it shouldn't be that complicated. And frankly, for me, it's a little bit suspect when folks push back on the idea of transparency. It raises a red flag for me in that this should be simple. If we're looking to grow a program that is doing what it says it's supposed to do, then this should be simple. We should be proud to be able to point to these numbers and say, here's how it's intended to work, and here's how it's going, and here's how it'll get better if it's expanded. The fact that that's not happening, I think, speaks even further to the need for transparency, because it tells me, okay, there might be something here that we really need to look at. And Sally is right. It's regulated on the federal level, but as the administrators of the program on the state level, we really do have an opportunity and an obligation, I think, to step in. And fundamentally, these are our people. These are our communities. There's a librarian who came to a panel that I'd done about 340B here in Albany at a conference, and she told us that her coworkers had to do a fundraiser to support the husband of one of her coworkers who'd been diagnosed with cancer and couldn't access his medicine. And she said, I wish I knew about this program then, because it was $4,000 a month and we were just trying to help them raise the money. That's unconscionable that someone is going through this harrowing moment in their life and they have to rely on the kindness of others. And even the kindness of others in communities like the South Bronx can only take you so far. So the gaps are really in not asking for the information. And that's why we've crafted the bill to do just that.
Absolutely. Specifically when it comes to politics, it is often said common sense isn't so common. And when it comes to these kind of situations directly impacting community individuals, and that impacts their everyday lives, and that's just another barrier of a health disparity in our communities. And I want to kind of touch on Garina with this question, being that you were a patient who experienced this firsthand. As many of you know, many Black and Brown consumers are unaware of the program, yet they stand to benefit or lose the most from how it's implemented. What role, in your opinion, does community education play in strengthening the impact of 340B? And who is responsible for leading that work in the community?
Great question. The community should be educated by this, by the 340B program at the state of initial diagnosis, at the hospitals, at the clinics, the social workers. Those are the people that should be gathering this information to help those in the community. There should be flyers. There should be some type of document circulating throughout the hospitals, because at the state of initial diagnosis, even as I'm a mentor as well, and I get called on to mentor women who are recently diagnosed with breast cancer, that's within my age range. And a lot of them, I have to try to encourage them to trust the medicine, but they don't want to trust the medicine because they don't want to cure the debt. And they shouldn't have to choose their life over medication and over debt. So if this program is designed to help those who are low income and who need this assistance, and it's not being used in that area, and these people within that community that are supposed to benefit from this program are not being given this information, and it's not being shared within a community, and it's being gatekept from those that need it the most, that's something that I believe that the hospitals, the social workers, even the doctors, this is information that they should be able to share with the community.
I appreciate that perspective, and that just brings us to the next question. Simply, where are the dollars going? What mechanisms currently exist or should exist to ensure that 340B savings are visibly reinvested into frontline care for under-resourced communities, especially Black and Brown neighborhoods? Sally, I know there was this national poll that came out today. If you can kind of shed a light on that through this poll as well.
Yeah, the poll that we did polled 10,000 Americans across the country about medical debt, and the numbers vary, but it's about 100 million Americans have had or will have or currently have medical debt, and much of the time medical debt can be very crushing. I mean, you could have an emergency appendectomy and go to the hospital. That could be $25,000, $30,000. There was a woman who had emergency delivery of twins, and they had to go to the NICU for an extended period of time. And she and her husband, it was an $80,000 bill that she was carrying, and there was no way she was going to be ever pay that. So it's crippling and crushing. And that's why we need these kinds of programs to help the very people they were intended to help. And as the assembly member noted, what's wrong with transparency? Why can't you tell us exactly where that money is going? And if it is going to the places it should, good. Then we know the program is working. If it's not, the program needs reform, and we need to make sure those dollars are going where they're supposed to go. So let me just talk for a moment about this survey from New York. We found that 2 in 5 adults in New York have had medical debt at some point in their lives. And among New York adults with previous or current medical debt, 58% have incurred the debt due to an unexpected injury or illness, or they've received a surprise bill. Have you ever walked into a hospital and you're like terrified? You don't know if you have an emergency and you go into a hospital, if you're having an attack of some sort, or like Garina, you're dealing with a very serious acute situation where you're having an allergic reaction to drugs. You don't know what your bill is going to be when you walk out. You don't know if your insurance is going to cover. There have been crazy situations where someone out of network comes in, a provider comes network, takes a look at you for 15 seconds and then sends you a bill for $5,000. Those things have happened. So it's one of the areas, and I say this as a consumer advocate, we all like to know what things are going to cost up front, but it's one of the few areas where you don't know how much a bill is going to cost and what the burden is going to be on you and your family when you walk out. But you got to get the treatment. Like Garina, we want to make sure people are not getting treatment because they're afraid of the cost. But we don't have the kind of transparency in healthcare in general. And I think hospitals are among the worst. I don't know. I mean, I'll walk into a hospital or I'll walk into a doctor's office and they'll prescribe me something. I'll say, how much is that drug? How much is that a month? Is that going to cost me $3,000 a month? What's the out of pocket? And they can check. They can find out. Hospitals are not so good at it, though. They can't tell you going in what the cost is going to be going out. And I think that's a fundamental problem. And of course, communities of color suffer the most because the burden just falls much higher on people who really don't have the resources to pay but need the care. So I'm going to just do one or two other because I don't want to have people glaze over. But the numbers from New York suggest that the reason people go into medical debt is emergency care, labs or diagnostic fees, MRIs, X-rays, doctor visits. By the way, dental care too is very expensive, and that can drive people into medical debt as well. Doctor visits, hospitalization, ambulance services, prescription drugs are down at 37%, but that's pretty high. That can be very crippling.
Yeah.
So 4 in 5 New Yorkers want hospitals to expand the free or discounted care. 83% of New Yorkers they support requiring hospitals and providers to offer payment plans for reasonable payment plans with not gigantic interest rates. And 3 in 4 New Yorkers support preventing medical debt from being included on the credit report. And Garina, didn't you mention that, the credit report issue? Because once you get a bad credit report because of hospital debt, you can't get access to reasonably priced loans. You end up in the subprime market where the loans are 7, 8, 9, 10, 11%.
It's a domino effect.
That's how it works.
Yeah.
So, you have and we fought really hard to keep medical debt off credit reports, because it's not like you're going to Victoria's Secret or flying around the world. No, you had an emergency or you have a serious illness that needs to be treated and you've racked up debt through no fault of your own. And so that shouldn't weigh down or destroy your credit.
Yeah. I think that's very important, Sally, to your point. No, this is not Victoria's Secret. We're not going on a shopping spree. The fact that we have to determine if I'm going to go into debt to use this medication that I know could possibly save my life is a conversation that is just unfortunately mind-blowing. Not just for us, the listeners who's, learning about this program, but for the people that's going through it and that have been through it. I want to kind of double back to Assembly member Amanda. Are there best practices either from within New York or even nationally where 340B savings have been clearly and equitably directed to improve health outcomes in Black and Brown communities, and what can we learn and scale from those examples if there are any?
I think there are certainly examples of hospitals that do a large amount of charity care. I think the problem is a bit nuanced in that a lot of those hospitals exist as safety net hospitals. So it's like hospitals that exist in the South Bronx. Lincoln Hospital is the hospital in my district. Lincoln Hospital is a safety net hospital. And so their charity care numbers are high, and that follows. Now, the nuance of the issue is that we need to get into some of the hospitals that maybe on paper are serving a particular amount of low-income folks, but the details of how the charity care is working remain a little bit murky. And so I think there are examples of people who do it well, but I don't know that the Venn diagram is an exact circle in terms of where we need the transparency and who's doing it well. I think it's for the folks who don't fall into that circle is really the reason that we need it. So in terms of who's got it 100% right, I would love to know the answer. I don't know off the top of my head if it exists, but I've got to tell you, I'm really alarmed by the fact that we see that there are companies making billions of dollars, hundreds of millions of dollars in profit, just because they're sort of facilitating. They're kind of pushing around paperwork, if you will, as it relates to this program. Again, that tells me that there's a bleed here that we're not accounting for. And when you think about what hundreds of millions of dollars could do for patients, it's really eye-popping when you put it in that context. And so that is, again, if there's a hospital who's doing it all right and has got it all figured out, that's not already operating as a safety net hospital, then we certainly want to know who they are and uplift them as a model. In New York, I hope to have that answer for you in about a year, right? I hope that we get some reporting and that we're able to see and we're able to point and say, these guys are getting it right. And if not, then in a couple of years when we figure out who's got it wrong and make them do it right.
Absolutely. To your point, Assembly Member, I think that is also part of the problem. Like, we know the issues, but there's really no resolve as of yet, hence why we are pushing and having this conversation. And I want to stay on the safety net conversation, and either one of you ladies can jump in. This is a free for all. As drug pricing debates continue nationally, how do we ensure that reforms to the 340B program don't unintentionally cut off safety nets for patients who already struggle to access affordable medication?
I'm happy to take a first stab at this. I think this is actually something that's come up here in New York. We have safety net hospitals who tell us that they worry that contract pharmacies who now would be subject technically to more reporting might be inclined to not do business with them because they don't want to do more reporting, and that obviously would have a cascading effect. Yeah. We just have to be honest brokers in this process. Again, it's 2025. Compiling a report of data that you already have is really not so cumbersome. And we're talking about, again, hundreds of millions of dollars spent in these institutions, sometimes billion-dollar institutions, certainly can find the way to get this information, to compile these reports, and it's not going to break the bank for them. And so again, when I hear that, it gives me pause. And if there's a contract pharmacy that's saying, I'm not going to work with you if I have to share this information, then they probably shouldn't be in the space to begin with. And that's probably an indication that something is really wrong. And one thing that there's no shortage of, thanks to the free market, is someone else who will come in and do that same work. And so if contract pharmacies that are standing in the way and willing to put these safety net hospitals in that position, then that's a safeguard that we can also sort of figure out how to legislate around. But more importantly, those are actors that should not be in the space if you're not acting in good faith. And I think we need to be able to speak with a clear voice, with clear eyes, and with really firm moral understanding that that is wrong, and that we're not going to sort of be bullied by corporations who have a vested interest in seeing these programs continue to live in the dark.
Absolutely. Sally, Garina.
Yeah, I'd be happy to join in. I think that that's an excellent point. We all should believe in and embrace transparency in a program what the program does is it says, I've read the legislation recently, it says to drug companies, you have got to sell drugs at a huge discount, 50% or more, to hospitals, because hospitals are distributing those drugs at reduced cost and providing charity care to a huge, swath of the community. And in order for hospitals to be able to afford that, they have to be able to have drugs at these much cheaper prices. Now, the assumption was that those discounts were going to go to patients. What we find is not only don't they give the discounts, and I should step back because I've been very harsh on the hospital industry. There are good players like Assembly Member Septimo said. Yes, there are very important hospitals like in your district, or in other parts of the country. Ryan White health centers, community health centers, they cannot exist without these discounts. They cannot provide the care to patients because they do pass along the discounts. So we should be sure to separate those out. But they are happy to provide data to back up the fact that they are really being the good stewards of the discounts that they get and passing those along to patients. When we do need a much better understanding about how the program works. And listen, if I were a drug company, and there's no angels here, there's a lot of money to be made in healthcare, and there's lots of profits. to go around, including for the drug manufacturing industry. But I don't blame them for being angry that they have to give these huge discounts, and the discounts are not going to patients. And I want them to go to patients as well. So some of the players are doing the right thing. But we need to understand who they are, and we need to understand who the hospitals are and the contract pharmacies that are making money hand over fist and not passing along those discounts. And we need reforms so that patients can get the help they need and not fall into medical debt like Garina had to do, and not get. I mean, wouldn't it make a difference if your drugs had been very low priced or free?
Absolutely.
Sometimes they even mark up the drugs that they got a discount on. They mark them up, or they charge a list price, which no one pays, to the patient. So, greed knows no bounds. Profiteering in any industry will happen if we don't have guardrails and protections and transparency. And that's why we're fighting so hard here in Washington and on the state level. And there are things that can be done on the state level. You could require transparency on the state level, as you probably know. When I say you, I don't mean, I said members of state legislatures across the country. That's something, even though it's a federal program, there's nothing to say you can't require more transparency. And I know that's what you're working so hard to do.
I want to simply say, if the powers that be that can miraculously change this whole situation around today was on this phone call, what specific policy changes or community-driven recommendations would help preserve the integrity of 340B while expanding its reach for those who need it most? What would be your answer to that, to give to the powers that be today?
I would say show the numbers, show where the money is going, show where how this money is, the discounts are benefiting the community. Show the guidelines of how this program is being communicated to those that need it most. It is really the structure of the program, like give some type of transparency to show the community that that they are benefiting from this program. Because me personally, I've never seen a discounted drugs. My chemo drugs range from $18,000 to $20,000 to $18,000. And then for me, because I was allergic to Taxol, my drug, which was now a very sensitive allergic, a drug that had to be mixed when I was going to chemo, when I arrived at chemotherapy, that drug itself was $30,000. I've never seen a discount. My debt had to go to collections because I wasn't able to continue to afford my co-pays. I was one of the ones that had to create a GoFundMe account, and it was only for $5,000 because I had negotiated with my creditors to do settlements on my hospital debt. And then I started looking at my bill statements and noticing that I was being double charged for services. So it was things that was appearing multiple times. And I'm like, well, I paid this. And they're like, oh, well, okay, well, let us go back and look at it again. And I was being billed again. So it's very important to pay attention to your bill statements as well while you're going through treatment, because they will keep accumulating, and you'll think that it's the same bill, and it's not. It's something, it's the same. You're being treated for the same thing, and you're paying double for the bill. But the drugs in itself, my new drug that I'm on is $20,000.
Wow.
$20,000. And I chose to continue to receive treatment because I know that there's more life in me to live. And that is the reason why I continue to choose these drugs and go into debt, because I know that either way I'm going to pay it, because I want to live. But if you don't want to live and you don't feel like you have anything to live for, I know that there's more life in me. There's more to live for. So it is that show us how this program is working for us, and who is like, I know there's numbers that, consider you as low income, but this program should work for not just low income people, but for anyone that is being treated with cancer. Like this program should work for anyone that is being treated with cancer, and that information should be shared to help them and to let them know that they can live and they don't have to worry about their debt at that time.
You hear these stories, but to hear it from the mouth of someone who's actually experiencing it is definitely chilling. And to Assembly member's point earlier, to have to already go through the process of accepting the fact that this is what's happening to you, and now having to worry about finances and figuring all of these different loopholes. I mean, that is why we're having this conversation today. And that is why the conversation must continue for people who are like Yarina. This takes me to my next question. This goes for Assembly Member Amanda and also Sally. What specific policy changes or even community-driven recommendations would help preserve the integrity of 340B? Like, how can we really just fill in this loophole here?
Do you want to go first?
Sure. Yeah, I do think state bills that call for transparency. It would be great to have an ombudsman, a billing ombudsman required in every single hospital. So poor Garina doesn't have to walk through her bill and see that they have double charged her, that they're not extending discounts to her. I mean, the average consumer has really not the time, the energy, the wherewithal to go through these complicated bills. I mean, we've all been through it, and I'm a fairly educated consumer, and I don't know what they're charging me for. So I think maybe all the hospitals have to, and they won't like this, but they have to provide someone to walk through bills. They should have an effective appeals process. I have a personal story that I don't have time for here, but it had to do with my son, and he's fine and was fine. But boy, did they take advantage of him when he walked in with something very minor. And all of a sudden, he had thousands of dollars for 3 hours of care, and they will do that. And there was no one there who was interested in talking to me about it. And I tried to raise Cain about it, but Garina, I feel so terrible for you because you're undergoing this terrible illness, which should be the thing you're spending all of your energy on. And instead you're having to fight with the hospital, and they don't have a lot of sympathy. A lot of them are owned now by private equity firms and things like that. So if you're going to be that, if you're going to be all about profits, then you got to provide some services to the people in the front office. And you've got to have a billing staff that says, listen, we'll make an appointment. Let's walk through. If there's mistakes, we'll correct them. And we're going to extend to you the discounts that are available to us, that sort of thing. So I don't know how we do that. I thought oftentimes we needed that in the hospital setting. And then, of course, we need to close these loopholes in the law.
Absolutely. I know, Miss Sally, you have to go in about 2 minutes.
I'll stick around because I want to make sure that we give a proper closing to this. And I love being here with my fellow consumer advocates and elected officials and patients. So I'll stick around for a few more minutes. And of course, our wonderful moderator, Ebony.
Well, thank you. We do have 15 more minutes. So Amanda, let's finish this conversation. Please feel free to share your thoughts on that.
Yeah. So I think, obviously, I'm partial to think transparency is the first very critical step to making sure that we're understanding what's happening, understanding the lay of the land, and really thinking about policies from an informed perspective. But some of the, if what is happening, if what we suspect is happening is actually happening, that these savings are not being passed on to patients in the way that they're supposed to. I think Garina had a great point. We should be mandating communication on this program. There are many things that patient care providers are obligated to share, this should certainly be on the list. If you are treating people with illnesses that would qualify them for drugs that are under the 340B program, you should have to disclose that to them and let them know that, and give them access to that program. That's a basic sort of communication policy that I think would make the world of a difference. But I also think that we should be thinking about the role of all of the different parts of this system. So when you're talking about contract pharmacies being able to change the pricing, being able to mark down up to their discretion, we probably need firmer guardrails around how much money you can make on a certain product, especially if you're receiving it at a discounted rate because of a government program. So that's another idea that sort of comes to mind. But I think really transparency is the first step, so that we can then appropriately scrutinize where are the holes, where are the gaps. But right at the outset, we know that we don't have enough more information, and we know that patients aren't getting the information they need. So I think those are two critical places to begin.
Absolutely. This next question is for all of you amazing ladies. Some hospitals participating in 340B serve both insured and uninsured populations, right? How do we hold institutions accountable for using those funds equitably without overregulating healthcare systems already under pressure?
Great question.
Well, Garina was insured, but her bills got so high, and they were one after another, and they're for treatment, and they're for drugs, and they're for hospital stays, and seeing specialists. And so at some point she was driven into, I can't pay the debt, and then it becomes a burden on her credit. So that's a problem. She came in as an insured patient. She said, Garina, you said you had a good job and good insurance, but apparently, it's fallen short for you. And that's not okay. And I think a hospital should be able to say, look, we've got a patient here who's now got a burden and has, I don't know if it turned into medical debt, but of course it's on your credit report. Now it's medical debt that, and I don't know if they're chasing you to get it paid back, but you can't get blood from a stone, I always say, if you don't have the money. But look what's happened to you, because you're trying to stay healthy and get the treatment you need. I mean, it's a terrible case, and it shouldn't happen like that. So I don't know what the answer is, but here's somebody who's well insured and is ending up in with a, I don't know. I'm not going to say you're in poverty, but if you've got medical debt on your credit card, that's not a good thing to have to deal with. And you're dealing with an illness. So it's added stress. It's a classic case of how our health system doesn't work.
Yeah. And like Sally said, I was insured. So I feel extremely bad for those who are not insured or underinsured. That made their debt. I'm thankful that I was able to pay my co-pays, but my hospital stays from my double mastectomy and my radiation treatment and my oophorectomy, which is a continuance of treatments that will have to go on, as preventative measures to continue to keep me alive. So it was just debt after debt after debt after debt. So if the debt that I accrued from going through all of my treatments was $50,000-$60,000, and and I was able to take money out of my 401, like having to take money out of my 401k at 36 years old, to pay for debt, and it's like I should not have had to do that, So I feel bad for those who do not have the resources to even pay for their co-pays, because having to go to the doctor 3-4 times a week and having to pay a $50 copay every single time that you go, when you don't even have the money or the transportation to even get to the doctor's appointment. And a lot of people don't even have the money to even take an Uber or a Lyft to get to their doctor's appointments. So that's another issue, that people don't even have the resources to even make it to their doctor's appointment, let alone make it pay their co-pays, let alone pay the debt that they have. They will continue to incur for the rest of their life as they fight through this disease, because it's a continuous thing. I'm still today taking medication because of a diagnosis that I received 6 years ago. So and that debt is continuing because I take a pill now that's $20,000. The first one was $18,000. Now this one is $20,000. So it's a continuous cycle. And if there are resources that can help those that really, really, really need it, and that do not have to choose life over debt. That's my thing. Like I don't feel that a person should have to choose whether or not they're going to live and not leave their family in, if they're going to live and leave their family in debt, and they have children, small children. And that is so sad. I think about it all the time. Like my daughter at the time when I was 36, she was 16 years old. So my fight became purposeful because of her. So, and so that debt that I accrued, I'm just like, whatever, I eventually it'll get paid. And then once I got the debt off my credit report, once it went to the creditors, then I was like, okay. And then once they passed the law that medical debt cannot fall onto your credit report anymore, I was like, okay, so it'll just sit in collections then at this point, and then I just make some type of payment arrangements to pay it, which I did. It is paid in full now, but,
they repealed that law, by the way. They repealed that law. Did you hear that?
I did not.
Yeah, it's the CFPB. It was a CFP, Consumer Financial Protection Bureau regulation. And this new administration has decided it's not necessary. So their intention is, I don't know if that's a final, but that their intention is to basically lift the prohibition on medical debt being on your credit report. So I'm glad it worked for you, though. I'm really glad it worked for you.
That's unfortunate. Go ahead, Assembly Member Amanda.
Very quickly on the question of how do you get to the heart of the issue without overburdening hospitals that are serving our really critical communities. This is something that I think about because I have this transparency bill, but I represent a safety net community and hospital. Again, I think what we're trying to do, especially here in New York with this bill, is get to the heart of what's happening with this program. If we hear common sense objections from hospitals as to how this bill is written or how this approach is happening in a way that's too burdensome for them, then we will certainly take that in, because what we want is to get to the heart of the program and make sure that it's running well. And so if we need to make adjustments, we'll do that. But to have just a total opposition to transparency is alarming. And that is where we have to really push back. And again, speak with a clear voice and say, you can't run institutions where your CEOs are making over $10 million a year, but say that somehow reporting on this program is going to break the bank for you. We have to just be honest. We have to be honest brokers, and we have to speak clearly about what's happening. And there's a breakdown with this program right now, and we need to get to the heart of it. And that's going to mean everyone has to work together. So I just want to underscore that that's a balance that we're really careful and we will continue to be mindful of. But hospitals need to come to the table as partners.
Absolutely. I want to wrap this conversation, this amazing, educational, informative conversation up with this last question. And we only have 5 minutes left. So if each of you can take about a minute to respond. And the question is simple. How can we better track the outcomes of 340B savings to ensure that health equity, especially in Black and immigrant communities, isn't just a talking point, but a measurable result?
I'm just going to go with the obvious answer of transparency. Our bill would require an annual report, again, where folks would have to say, how much did you pay for the drugs? How much did you take in savings? How much did you spend in charity care? And in an ideal world, those numbers line up. And that's the first step. But I think another sort of critical piece, like we mentioned before, is making sure that patients also are fully aware that they have access to these programs, so that we're not only making sure that utilization goes up, but that it really gets to the heart of the people who need it.
I agree with Amanda, that the transparency and the communication to the patients and letting them know that this program is available for them, and asking, like, I know for sure that for me personally and from other people that I have spoken to, that's, within the cancer community, that they've never heard of this program at all whatsoever. So there is a break in the communication of this program being communicated to them. So I truly believe that if the communication from the hospitals is delivered to the patients, that would be very helpful, and with the patients that need it most, and how their drugs, and even a list. I even asked the question a couple of days ago: is there a list available to show which drugs are being discounted for the patients? Or, can these patients, is there a list available that these patients can see to see if their drug is on there that should be discounted? So it's just communication.
Yeah, thank you, Sally.
Yeah, that I think a list of drugs that should be discounted would be helpful. Yeah, I don't want to repeat myself. I'm for transparency. I want patient assistance. I want hospitals to understand that people shouldn't be driven into bankruptcy because of their medical costs, and they should do everything they can to provide charity care. I mean, maybe there was a time at which, Garina, you needed the assistance of the hospitals. That's why they get the discounts. Even if they don't discount your drugs, they argue, oh, well, it's providing us other opportunities to provide discounts. Well,
Absolutely.
because of the costs, the hospital costs, the drug costs, the provider costs, the doctor costs, they've driven you to the brink of financial peril.
Yeah.
So that's something I don't know if we can deal with legislatively, but we certainly can look at shifting the burden, as Assembly Member Septimo has said, shifting the burden onto them. Show us what you're doing and how you're working with this program. And I do think they should provide help to people who need to get walk through bills and be required to provide that kind of assistance, so that you're not getting double charged, or you're getting list price or more charged for a drug that they're getting a deep discount on.
Yeah. I think it is as plain as day. And for those of you who may have joined us a little later, it is now our time, but I do want to give this package with a little bow. I want to wrap it up and give it to you guys. If 340B was done right, patients in our community will have less financial burden and medical debt. If 340B was done right, hospitals' use of 340B funds will be tracked, measured, and there will be accountability. If 340B was done right, there would be benchmarks for how much 340B revenue hospitals reinvest into patient care. The red flag is there is no way to properly check 340B. The 340B program was designed to support hospitals and clinics serving low-income patients by providing discounted medications to those who need it the most. If no one knows if 340B is getting reinvested into patient care, financial burdens of people in our community could be avoided if 340B was done right. At blackdoctor.org, they urged reform that 340B program prioritizes patients over profits. Blackdoctor.org asks policymakers to implement reforms that enforce transparency, ensure reinvestment in under-resourced areas, and hold all accountable to monitor when 340B money is going. This conversation has been super powerful with the Miss Sally Greenberg, Assembly Member Amanda Septimo, and Miss Garina Ross. I'm Ebony J.J. Curry, journalist here in Michigan, and we appreciate your time. Thanks for watching. Thank you, ladies, for being here.
Thank you.
Thank you.
Thank you all.